So after going over the basic molecular pathogenesis, risk factor, and the prevention of the colorectal cancer, now the next important step which we will discuss in this section is the treatment and the staging of the colorectal cancer or the cancer of the colon and rectum, because staging and is important step that tells us what is the prognosis and what will be the outcome of the treatment and how we can treat this cancer. So staging and treatment will be discussed in our fourth section of the lecture. Staging and prognostic factors. Prognosis is the how well is the outcome and what's the prognosis, how well it can be treated or managed. So prognosis and the staging. Regional lymph node involvement is one very important prognostic factor. If there is no regional lymph node involvement, the staging is early, and with the early staging there is better prognosis. So you see there is stage 0, very small, little, no tumor or growth is present. Gets bigger in stage 1, then we have stage 2, stage 3, and then the stage 4, again where there is actual spread to the adjacent organs and to the lymph nodes also. So these are the different stages of the colorectal cancer. Distant metastasis, the other important prognostic factors. So the prognostic factor are mainly the metastasis to the regional lymph nodes or the involvement of the lymph nodes, and also distant metastasis or spread of the tumor to the distant sites. Then TNM classification, tumor node metastasis classification, is another important prognostic factor. Stage 1 is T1, 2, and there is no nodal metastasis and no distant metastasis. So both stage 1 and stage 2, according to the TNM classification, stage 1 is T1, 2, and there is no tumor and no node involvement and no distant metastasis. Do not involve regional lymph nodes, no penetration through submucous or mucus or muscularis layer. Then in stage 2, we have is the T3, tumor is at the 3 level, 3, 4, and there is again no node and no distant metastasis. Penetrating muscularis, no spread to the regional lymph node. In stage 3, we have N1, 2, and no distant metastasis. So there are lymph nodes involved, 1 to 2, regional lymph nodes are involved, and there is no distant metastasis. And then in stage 4, there is metastasis spread to liver, bones, etc. So these are the staging of the colorectal cancer. We have stage 1, which is no node involvement, no metastasis. Stage 2, no node involvement, no metastasis. Stage 3, there is involvement of the regional lymph nodes 1 to 2, and there is no distant metastasis. But in stage 4, there is actual lymph spread of the tumor to the areas like liver and the bones. So this is the staging of the colorectal cancer. Intraoperative and pathologic staging measure CAE levels and CT scan. So one method of staging is also pathologic staging, is carcinoembryonic antigen. So this is the measurement of that level, and there is CT scan should be performed. What are some predictors of the poor outcome of the treatment? Predictors, we have very important tumor spread to regional lymph nodes. If there is spread of the tumor to the regional lymph nodes, that is a poor predictor of the outcome. Regional lymph node involved. Tumor penetration through the bowel wall. If there is penetration of the tumor through the wall, this tumor, if it is penetrated through the wall, then it's the poor outcome. Poorly differentiated histology, as I mentioned so many times in previous lectures also, differentiation is very important factor in the prognosis. So poorly differentiated cells are the factor which is the poor predictor. So poorly differentiated histology. Perforation of the wall of the intestine or the colon is another poor predictor because of the infiltration of the wall with the tumor or the cancer. It can cause perforation and also it's a poor predictor. Tumor adherence to the adjacent organs, venous invasion, preoperative elevation of carcinoembryonic antigen is another important, more than 5 nanogram. Aneuploidy is another factor, and chromosomal deletion of BRAF gene. So all these are the factors associated with the poor outcome of the treatment of the colorectal cancer, in which the spread or metastasis to the regional lymph node, distant organ, perforation to the wall of the colon, and then perforation and penetration are the other factors that are associated with the poor outcome. Venous invasion, because once the veins are invaded, it can spread to the distant organs rapidly. So all these are the factors that can cause rapid spread and poor outcome. Treatment is the total resection of the tumor, stage 2 or stage 3. So total resection or total removal of the tumor can be done, especially in stage 2 and 3, because the tumor is not spread already to the distant organs and it is localized so far. Nodes are involved, so total resection is effective. Colonoscopy of large bowel, laparotomy, opening of the abdomen, and direct visualization of the extent and the spread is effective. Radiation therapy to pelvis, total mesorectal excision, and 5 fluorouracil based chemotherapy. So these are the treatment options for the colorectal cancer. Next treatment options are combination of chemotherapy and radiation therapy, administration of leucovorin, topoisomerase 1 inhibitor, FOLFIRI regime, which is usually the FOLFIRI and FOLFOX, oxaliplatin, and which is platinum analog, monoclonal antibodies, EGFR administration, and radiosensitization. So all these are different treatment options in which we have combined radiotherapy and chemotherapy. Only the chemotherapeutic drugs when there is regression of the tumor with the radiation and chemotherapy combined. So all these different drugs can be tried for the treatment of the colorectal cancer. So this was all about our screening and the treatment for the colorectal cancer. Thank you for watching sqadia.com.